This is the mental nerve block. The mental nerve block gets soft tissue only. It also gets no teeth. So the buccal and the long buccal and the mental nerve block only get soft tissue. They do not provide any kind of pulpal anesthesia. You need to remember that. So the mental nerve comes off of the inferior alveolar nerve, and you can see that it comes straight down, and then part of it comes out of the mental foramen down there on the bottom, and it will provide soft tissue to just the premolar section. So you can see that there's nerves that go clear over onto the, below the incisors. And so we'll be talking about that in just a little bit. But right now, if you just give a mental, you're going to get just soft tissue. So this injection is also going to anesthetize the lower lip and the skin of the chin to the midline. So when you give this injection and you say that you wait the 3 to 5 minutes and you say, are you feeling numb? That's where they should be feeling numb, on the lower lip and the skin, all the way to the midline. So you deposit where the mental nerve enters the mental foramen, and it merges with the incisive nerve and to form the IA nerve. So the location of the mental foramen is usually between the apices of the mandibular first and second molar. The ideal thing is to look at a pano, because you can see exactly where the mental foramen is. A lot of times on a full mouth set of x-rays, sometimes you can see the mental foramen even on there. But if the person who was taking the x-rays didn't get far enough down, then you won't. But for sure on a pano, you always see where those two dark lines are, and that'll become important when you give this injection. There are two approaches to giving this injection for the operator. You can position yourself at a 12 o'clock right behind, and you can see to where she's able to go ahead and just put the syringe straight down, and you can be almost parallel with the long axis of the teeth and go right in. You want to stop your needle from penetrating further down than the where the mental foramen is. You want to go higher than the mental foramen, so gravity will pull that anesthetic into the mental foramen. That's the idea. And so you can give it behind, or you can give it from the side and approach it from coming inside. I think it's far easier to give it when you're sitting at the 12 o'clock position. If you guys think it's easier for you to give it from a front position, you can do that, but most everybody likes giving it from the back. You have a good visual, and the only thing is the patient obviously can see the syringe, so you might want to have them close their eyes if they're a little squeamish. This is showing a position where the operator might be at 9, 10, or 11 o'clock, and they're giving a right and left mental foramen. You can come in kind of sideways and give that from the barrel of the syringe, coming in just straight. This is another approach, the vertical approach, just coming straight down with the clinician at the 12 o'clock. And I added this picture in here again to show you how the difference of how you can put your index finger up on your non-dominant hand and kind of steady the syringe barrel. So when you're fulcruming, so you're going to pull the tissues and make that tissue really taut, and you can see that how far away that you are going to be injecting, kind of at the top of that fleur-de-lis or whatever that is. The point of it is probably where you'd want to penetrate that tissue. It'll be a little bit away from about, I don't know, 4 millimeters or 5 millimeters away from the actual fold down by the teeth, and that's perfect because then you won't be accidentally putting your needle closer to the mandible, because it will scrape right down that bone. But just like the maxillary teeth, if you pull the tissue out and deposit there, and then when she lets go of that, that buccal mucosa is going to fold right back up close and hug the teeth, which means that anesthetic is going to be right where it needs to be. So that works out great. This is just showing a really good view of how you would do this, like picture one is if you're coming from a front position and she's putting on topical or just showing a position, but your syringe would go there too at an angle. And of course, number two is the vertical approach. So what you want to do is you do not want your needle going into the foramen. You want the needle to be at the foramen or above the foramen. So the gravity will, like I said, pull the anesthetic into the mental foramen. So if you can't find it on x-rays, another way is that if you palpate down really far into the vestibule with your finger and start kind of at the first molar and come straight up. You just palpate every few millimeters and press in lightly, and all of a sudden you'll feel where there's a depression, and that is the mental foramen. Some people can feel it if they do that on the outside, put their fingers on the outside of their bottom cheek and come down. They can feel where that is. I have a hard time doing that because all of the fossas, depressions in between the roots of the teeth, I'm not sure if I'm feeling a depression of the fossas or if I'm feeling the actual mental foramen. But you can, it's there. Sometimes it hugs more the first premolar, sometimes it's back and it's kind of hugging next to the root of the second premolar, and very often it's right in the middle. But you want your needle before it. This is showing the needle behind the mental foramen, but when you're actually in the mouth, you want it before, because remember, they're going to be laying down. So you want it before and before it, and or in front of it, I could say, and above it, so that from either side, gravity will be able to pull it into that foramen. You're likely to get a failure of anesthesia if the needle goes in further down, because it'll just keep going downward and won't come up to that foramen. Even if a little bit of it does, you won't get really profound anesthesia. So for this, of course, you're going to use a short. It's a 25 or 27 short. The area of insertion, the mucobuccal fold, or just anterior to the mental foramen before it. The target is, of course, the mental nerve as it exits the mental foramen, and the landmarks would be the mandibular premolars and the mucobuccal fold, which makes sense. The bevel is always toward the bone, and patients should partially close. They don't open their mouth super wide. You locate the foramen with your index finger. It's usually at the apex of the second premolar, but as we talked, it could be before that. So you're going to direct the syringe toward the injection site at the canine or the first premolar because you want to be before it, but just a teeny little bit. You go down, look at this, again, 5 to 6 millimeters only of your needle toward the foramen. So you aspirate twice, and then if that's negative, you can deposit 1/3 of cartridge over 20 seconds. If it swells, it starts to balloon up and swells, you want to stop, you want to take your needle out, you wait until all of that can diffuse a little bit, and then you may need to re-inject. And on this one, you just need to wait about 2 to 3 minutes. So how can you tell if you have had a successful injection? They're going to feel tingling or numbness of the lower lip. So they are going to have paresthesia of the lip or chin. If the needle contacts the middle nerve, they're going to have a little electric shock, or rare slight paresthesia transient because it will go away. But this electric shock, it does just feel like that. It's like just a second, if that much, maybe even half a second, that you feel this little zing because your needle has just passed slightly by it and just kind of grazes it. It doesn't go into it. The nerve, definitely if you would happen to hit into a nerve, it would give a bigger electric shock, but your needle can just barely brush past it, and they're going to feel this little shock and they'll just jump a little. So it's perfectly normal. It's an anatomical safe area. And remember that you don't have any anesthesia of the teeth or lingual. It's just soft tissue of that facial side. The only thing that's going to give lingual anesthesia to that lower arch is when you anesthetize the lingual nerve along with the IA. So some people, I debated to say this, but some people like to tell their patients that they may feel a little shock and that it's normal, but sometimes that just puts it so in their head that they think any little thing, it must be that electric shock, and they get kind of scared of it. But if it does happen, there's plenty of times it doesn't happen. But you're going to, in your lifetime, probably give a mental that does give a shock. Just be prepared for it. It's not a big deal. This is another example of needing to have a really firm fulcrum so that if they kind of jump a little bit, it doesn't cause you to pull out of the tissue or anything. So complications with a mental block could be just a hematoma, or a bruise. It rarely occurs, but it could. This has a really high success rate. It's easy. It's usually not traumatic at all. Positive aspirations is a little bit more. It's maybe closer to 6%. But I don't know. We don't get very many of them in reality. The technique adjustment that you would do is apply pressure with gauze to the area and reassure the patient. And the reason that you're applying pressure with gauze to the area is that it does help with the hematoma or the bruise not becoming quite as large. And by the way, when you're giving an infiltration, that you're going down, and just guess what, 5 millimeters. So that seems to be a really good number in order to allow you to memorize all that.